Today, I'd like to talk to you about what's new in 2020. I think you got to hear a fair bit of that from the research that's come out of Wake Forest and Dr. Levine as a group there. They've done a tremendous amount of work in this field. They've been publishing quite a bit this year. I do want to also thank the ACPMP Research Foundation for all the support that they've given over the years for these symposia to bring information to patients and their families, and as Dr. Levine mentioned, to bring everybody together so that you know that you're not alone. This is a difficult, challenging disease. As Dr. Levine said, it is a rare disease, and it's really easy to feel like there's nobody else who's experienced this as you are going through. And so it's wonderful to have a group like the ACPMP that brings resources and brings people together around this this problem. So without further ado, I'm going to kind of jump into what's new in 2020 with regards to appendix cancer. And as I was preparing for this talk, I started at the obvious place, doing a Pubmed search. Pubmed is the major search engine for medical information, and just put in appendiceal cancer, and this timeline popped up. And what you can see is that from 1945 to 2019, there has just been a incremental trajectory in the number of publications around appendix cancer. ACPMP Foundation started in 2008, and you can see here at that time there was about 107 publications in the system under appendix cancer. Last year there were over 260. As of right now, this year we're a little over 200, but we're only 3/4 of the way through the year. So if you do the math, we have a projected greater than 260 publications. And I suspect that this has probably been hampered a little bit by the COVID virus. So there probably would be more publications if that hadn't happened to us. There, again, going through the most recent literature, it's really been an exciting time. It's been great to review the past year. There are a number of things to highlight. Obviously, I'm not going to be able to go over all of them. Dr. Taraga is going to speak to us about the Chicago Consensus, which I think is one of the most important publications that has come out this year. It's also exciting to see that there are currently 8 clinical trials available that are specific to appendiceal cancer. There are a number of publications about advancing surgery and the use of intraperitoneal or regional treatments, such as like Dr. Levine spoke to you about. Again, there's a huge interest in better refining the pathology. Despite efforts of a number of people, it is still often very confusing, very humbling to try to sort that out, but people are still working diligently on that. People are definitely focusing on improving patient selection for the right treatment, especially for the cytoreduction in HIPEC, which, as Dr. Levine mentioned, is a daunting and challenging thing to go through. So as HIPEC surgeons, we really want to make sure that we're picking the people who are going to benefit the most from it and be able to really benefit from that treatment. And also better determining prognosis. I think that's probably one of the most frequent questions that we get asked is, what does this mean for me? And the more information that we have, particularly around like the genomics, as Dr. Levine talked about, the better we are at helping people to sort through those difficult and challenging questions. What I would like to focus on, though, in my talk are a couple of things that Dr. Levine also touched on as well. And that is, first is the rising incidence of appendiceal cancer. There's no question in my practice. I feel like, obviously, I see a lot of people with appendiceal cancer because we have the HIPEC program here, but I kind of feel like it's an epidemic. Sometimes they're just, Dr. Levine said he saw 3 new patients today. Every week I'm seeing new patients in my clinic as well. So it definitely feels like the incidence is rising, and now I think we definitely have data to show that. I also want to talk about the risk of appendiceal cancer with complex appendicitis. This has also really come to the fore, and it's changing the way general surgeons think about the appendix and appendiceal cancer, which I know is one of the major goals of the ACPMP Research Foundation, is to bring awareness to the general surgeons and get people referred to high volume centers early. I also want to talk about the potential role of the immune system in outcomes for appendiceal cancer, and then the evolving role of something that's called a liquid biopsy in appendiceal cancer. I'm starting to see this more and more. Our medical oncology colleagues are ordering these liquid biopsies, and it's kind of interesting to see what the role might be for appendiceal cancer. So we'll start with the rising incidence of appendiceal cancer. Dr. Levine showed you some data in his talk that showed this as well. But this is a recent study that was published in Cancer in this year, titled Continued Increasing Incidence of Malignant Appendiceal Tumors in Canada and the United States. This was a population-based study out of Canada. The authors were from Canada. They looked at the Canadian Cancer Registry and the US SEER database, which is a large national database that looks at the incidence of cancers. And they looked from 1992 to 2016, and what they looked at both any tumors of the appendix, so including the mucinous adenocarcinoma types of tumors that Dr. Levine focused on, as well as the carcinoid or neuroendocrine tumors, and both have been rising over that time period. But specifically focusing on the adenocarcinoma, this study showed that in the United States across all age groups, and they started looking at the age of 15 going over 80 years old, that there was a 44 to 147% increase in, that's just in the adenocarcinomas alone. If you include carcinoids, it was well over 200%, like what Dr. Levine mentioned. And in Canada, it was even higher, so 45 to 451% over that time period. The other findings that these authors noted was that the majority of the adenocarcinomas were being diagnosed as stage 3 or 4, meaning that the tumor cells that started in the appendix had either spread to the lymph nodes alone, which would put a person at a stage 3, or most likely in the abdominal cavity, which would put the person at a stage 4. Interestingly, they found that there's been a steady rate of appendectomies. So this increase is not due to surgeons doing more appendectomies, and it's also not likely due to increased diagnosis of just incidental asymptomatic tumors that got picked up on a CT scan for another reason. The authors do kind of think about, like, well, what could be driving this? And some of the possible causes that they proposed are obesity, changes in our diet over that time period, certain lifestyle factors, the microbiome, which refers to just the constellation of bacteria that live in our intestine, where we know that the microbiome plays a very important role in colon cancer, that we see that the microbiome is different on the right side of the colon versus the left side of the colon, and we see very different tumor types in those two areas. They're all called colon cancer, but they have different genes involved in driving those tumors. Whether they are related or are directly causal, or they're just happen to be there at the same time, we don't know. That's still to be determined, but it's certainly something of interest in appendix cancer. And then also just changes in our environment that might be driving this. That is also another common question that we receive, is like, what caused this? What's driving appendix cancers? And because of this finding of this increased incidence, the authors are recommending appendectomy for all people who have appendicitis, or at least deliberate surveillance. In the recent past, within general surgery community, there's been a real push to try to manage appendicitis or inflammation of the appendix without surgery. Traditionally, the appendicitis has been considered a surgical problem. Somebody comes in with appendicitis, you go in, you remove the appendix. More recently, though, people have been trying to manage it just with antibiotics. And if the inflammation and swelling settles down, not necessarily going back and taking out the appendix. But this could actually result in people having a tumor of the appendix that's related to the appendicitis going undiagnosed, unremoved, and undiagnosed, and then presenting at a much later time. And so with that, I'd like to switch gears and talk about the incidence of appendiceal cancer in what we call complex appendicitis. So when somebody comes in with appendicitis, it may just be early appendicitis, like I said, with some inflammation, swelling around the appendix and pain, and they have their appendix taken out or treated with antibiotics. But sometimes people come present with a what we call complicated appendicitis, where there may already be the appendix has burst, There may be an abscess around that area, and things are more, or just so much swelling and inflammation around the appendix that it can't be removed safely at that time. And the management for that is to treat the person with antibiotics if you can. And then one recommendation is to do what we call an interval appendectomy, meaning you wait a few weeks and then you take out the appendix maybe 6 or 8 or 10 weeks later after the inflammation and swelling have settled down. But some people have argued that you don't even need to do that. If the appendix, if the swelling and inflammation settle down, you don't need to remove the appendix. Well, there have been a number of studies now going back to 2012. This was a study by Carpenter et al. From the southwest of the United States, from Arizona, who looked at 315 patients with acute appendicitis and 24 of those who had complex appendicitis. And 291 patients had an immediate appendectomy. 18 had what we call that interval appendectomy, where they treated with antibiotics for a period of time and then removed the appendix. And what was interesting was that they found that there were tumors in 1% of the appendixes that were removed right away, reflecting the data that Dr. Levine showed. But there was almost a 30% incidence of tumors of some sort in the group that had their appendix removed later. And so about a year later, Dr. Furman and I and my colleagues at the University of Massachusetts did a similar study where we looked at all the patients who had appendectomies for appendicitis. We looked at those who had interval appendectomies. There were 17, and we found almost exactly similar results. 2.5% of patients in the immediate appendectomy group had a tumor found, and almost 30% in the interval appendectomy group had a tumor found. Now, this is on the other side of the country, so this was in Massachusetts. So this wasn't just a regional thing, a local hotspot. This seemed like a real phenomenon. And more recently, if you look through the literature in 2014, 2015, others have published not quite as high, but significantly high rates of tumors in people who've had interval appendectomies, 10 to 12%. And in 2020, 2 more reports, 12.6% and 9%. But I want to take a minute and focus on this study from 2019, which was actually a randomized controlled trial performed in the Netherlands, where people who came in with complex appendicitis were actually randomized to either have an interval appendectomy or have surveillance with an MRI. And what this group found was that in the group that had the MRI, actually 20 people went on, of 30 people went on to need to have their appendix removed. And they found a 20% rate of neoplasms or tumors in the appendix in people who had complex appendicitis. And so this was, I think this is a real, and we see this all the time. When I get a referral for somebody who comes in with complex, when they have a new tumor diagnosed, I'm not surprised to hear that they had an interval appendectomy. So the good news about this is that, like here at the University of Utah, and I'm assuming at other institutions across the country, we have instituted a protocol where if somebody comes in with complex appendicitis, they will get an interval appendectomy. There is no more debate about it. And the reason that's driving it is the incidence of appendiceal cancer. And as I mentioned, we saw this in the Southwest, the Northeast in our country. One of the studies that I showed was from Korea, and this one was from the Netherlands. So this isn't a local hotspot environmental phenomenon. This is a global phenomenon that's happening. Now I just want to switch and focus on cancer, appendix cancer, and a little bit on the immune system. And I'm actually, Dr. Levine didn't share this, but I actually, as I was going through the literature for 2020, these articles from the Wake Forest group just stood out to me. And I think this is really exciting. He spoke about the importance of understanding the genome, looking at the actual mutations in the genes that are involved in these tumors to determine how best to treat people, how to anticipate how these tumors are going to behave, and how we can best help people. And basically what they have found is this very interesting gene signature involving immune genes and cancer genes. And they looked at 138 patients and look at the tumor expression profiles. These are all patients that had appendiceal mucinous neoplasms. And what they found was that these tumors really segregated very nicely. This is again this matrix type of plot that he showed, and what he showed, what they found was that there were some patients or tumors that were what they call immune rich, and this is in the upper left-hand corner here, where they were very heavily, they found a very heavy concentration of the immune-related genes. There were tumors that were called, that they termed oncogenic enriched, meaning that they were heavily focused on the cancer genes, the genes that were driving the cancer, and then this mixed population. And what they found was that these different gene signature patterns would predict both overall survival, with the immune-enriched patients doing better, that's the green line at the top, both in overall survival and progression-free survival. And the tumors that were the cancer gene or oncogene enriched tended to have a less favorable overall survival or progression-free survival. And their conclusions were that, as we've all come to know, but they've just really put the data behind this, is that these appendiceal mucinous neoplasms are cellularly heterogeneous, which means they're just really complicated at the gene level. And that it's not only just at the gene level, but involving the immune system, the stroma, which is the environment in which they grow in. And it really is this combination of all these things that are driving the outcomes for our patients. And that the low risk immune enriched subtype might suggest a role for the immune mediated control of these tumors in some patients, and may actually help us decide which patients should get immunotherapy and which patients should get systemic or more systemic type of chemotherapy if they have the onco-enriched profile. That is to be determined yet, but that is sort of how they're thinking. So this may be helpful to guide treatment, as well as helpful to guide surgeons at a time when cytoreduction is not necessarily, complete cytoreduction is not feasible. And that was the focus of their next publication also this year, where they looked at almost 80 of the patients in their previous study who had incomplete cytoreduction in HIPEC. And they found again that the patients who had the immune-enriched, the tumors that had the immune-enriched signature tended to do better than tumors that had the cancer or oncogene-enriched profile. And basically what they concluded from this study was that long-term survival can be seen in people who, for whatever reason, cannot have a complete cytoreduction at the time of cytoreduction in HIPEC. And that knowing this gene pattern signature of the tumor will help provide prognostic information and may help us guide surgeons as to how much surgery they should pursue at the time of surgery. And now I want to switch gears one more time to talk about something that's really new, that's it seems like it's really coming to the fore in cancer treatment, and that is the liquid biopsy. And what is a liquid biopsy? Well, some of you may have already had one, but basically it's a way to try to look at the presence of either tumor cells or the DNA from tumor cells in the bloodstream. And so basically it is taking a blood sample and then looking for what they call circulating tumor cells or circulating tumor DNA as a way of diagnosing, getting a look at the gene profile of a tumor without having to do a tissue biopsy. Tissue biopsies are obviously more challenging, more invasive, more expensive. But there's a number of questions about this. While this sounds like a great way to go about it, there's a number of important questions. Do the liquid biopsies reflect what we would see if we did a tissue biopsy? Are they the same? Are they reliable? Are they really going to help us determine prognosis and identify possible treatments for a person? So that we're still in that stage of gathering that information. But here are some of the potential clinical applications. It could be used for screening and early detection of cancer, either before it's been diagnosed or after somebody has been treated and we're following them for recurrence. We can potentially monitor therapy, like we routinely follow tumor markers like the CEA, CA125, CA19-9. Could we do, in addition to that, could we be following circulating tumor cells or circulating tumor DNA? Can it give us some information about the prognosis, about how this tumor is going to behave going forward? Can we identify therapeutic targets based on this information? and then stratify therapeutic interventions. And so this is, again, a really exciting area of investigation. It has been used, it is being used in breast cancer, prostate cancer, colon cancer, lung cancer, other more of the common cancers, but we're also starting to see medical oncologists use this in appendix cancer. But the question is, does it work in appendix cancer? As we know, appendix cancers are rare. They are very unique in many different ways, and they don't always follow the textbook of other cancers. And as Dr. Levine has clearly pointed out, appendix cancer is not colon cancer. It is its own entity. And so there's a number of studies that have, or a handful of studies that have started to look at the use of liquid biopsy for appendix cancer. This was one that was actually published in 2018, but I just want to use this because it builds the story. They looked at 213 patients with advanced gastrointestinal cancer, including 46 patients with appendix cancer, and they looked at the gene expression profile in the circulating tumor DNA. And basically what they found was that when they looked at the overall population, 58% of the patients were found to have at least one gene mutation in the circulating DNA that they could was actionable, was recognized as a tumor mutation. However, in appendix cancer, not surprising, only 24% of the patients that they tested had at least one mutation that was recognized. And when they went to look and see if these mutations might be targetable, meaning is this something that we have a drug that's either approved or FDA available, what they found was, again, that for appendix cancer, unlike the other cancers, there was only 24% of those patients that had the mutation. They were targetable, but only with an off-label FDA drug approved. So unlike some of the other cancers that they looked at, it wasn't as encouraging, and the authors actually specifically pointed that out, that while the utility of liquid biopsy is dependent on the tumor of origin, there were some tumors that were exceptions, and they specifically pointed out that appendix cancer seemed to be an exception within this group of tumors. There were a number of limitations to this study. There was no tissue biopsy to compare this to. It was a de-identified database. There were no clinical correlations. They didn't have any histology. This was just appendix cancers all together, lumped together. It was a very small number. And interestingly, there was a poor correlation between the type of mutations that they were seeing and previously published studies based on tissue biopsy. So the profiles weren't adding up either. This was then followed by a more recent study that was published in The Oncologist by the group out of Emory. And they looked at 372 blood samples from 303 appendix cancer patients. And they found that 184, about 50%, had at least one mutation. So again, not quite as good as the previous study that had 58%, but better than the 24% in appendix cancer. And when they looked at the expression profile by the histology, these were the tumors that they saw, the mutations that they saw, P53, KRAS, APC, BRAF, and this GNAS, which is the one that's most frequently seen, mutated specifically in low-grade appendix neoplasms, was very low. And so again, this sort of raised the question that, is the liquid biopsy really reflecting what we're seeing in the actual tissue biopsy? These authors concluded that it was feasible and reliable. They felt that the frequency of genomic alterations was similar to previous published reports on tissue. I am not as convinced of that, but they do make the point that the liquid biopsies are non-invasive, cost-effective, and hopefully a promising method for personalized treatment. Again, similar limitations to the previous study: no tissue to compare, de-identified database, no clinical correlations. And I felt that the study didn't correlate as well with previous published tissue biopsies. And then again, this year, this is a study from the MD Anderson Cancer Center that looked at 266 patients with appendiceal cancer, and they actually did compare blood and or tissue. They looked at either blood and or tissue tumor expression. And basically what they found was that when they looked at blood, the number of mutations was again much lower than what they actually found in the tissue cohort. There were only 24 patients that had blood only, and there were 230 patients that had tissue only. But when they looked at the most frequent mutations that we see, the RAS and GNAS, what they found was that there was significantly more GNAS mutations in the tissue than there were in the blood, again confirming that there isn't this, we're not seeing this correlation between the mutations that we're seeing in the tissue biopsy and what we're seeing in the liquid biopsy. And they concluded that there was a low rate of mutation, that the low rate of mutations in the blood-based analysis could be the result of poor shedding of tumor DNA by the appendix cancer. And it may be a grade-dependent phenomenon, meaning that low-grade tumors may not shed as much DNA, higher-grade tumors may, so that may be an important part. We do know that the spectrum of disease with appendix cancer is important. It's very, like, even though appendix cancers are not colon cancers, but all appendix cancers are not the same either. There's a great spectrum within the umbrella of appendix cancer. They also felt that the lack of concordance may reflect differences in the liquid and tissue cohorts. So these were not necessarily taken from the same person, and you may be comparing somebody who's had surgery and chemotherapy to somebody who's just been diagnosed. And so their recommendation is that we use these liquid biopsies for appendiceal cancer with caution. So just to summarize, what's new in 2020? You know, the good takeaways, I think, are that the data are starting to reflect what we're actually seeing in terms of the incidence of appendiceal cancer, which is going to raise awareness and hopefully interest and understanding. And like Dr. Levine said, funding for research. There's definitely an increased awareness among general surgeons, which is so important because they're often the first person who makes the diagnosis. And just making them aware that this is a real thing and that people need to be seen at a high volume center with experts in how to manage this is critical to early referral and better outcomes. The role of the immune system in appendix cancer is definitely unfolding, and this confluence of both the immune system as well as the genomics is really exciting. And I just congratulate Dr. Levine and his colleagues at Wake Forest for these excellent studies and keep pushing that frontier. And it's really exciting, I think, that appendix cancer is being included in testing of the most advanced technologies. Whether or not this is the right technology for it, it will be determined. But it's just exciting that we're there, that we're on the radar. And just finally, I think all of this just means that there's hope. And it's just an exciting time. Things are moving forward, and there's more good things to come. And I want to thank my colleagues at the University of Chicago, Wake Forest, the ACPMP Foundation for just helping us push this frontier, better understanding, and taking us forward. And I'm